So basically, the rationale behind our study was to identify a new performance metric that may be associated with long-term survival and maybe a more useful metric to identify hospitals that are high-performing and low-performing, and then determine what drives the performance and how it influences long-term outcomes. The current paradigm in the United States is that hospitals are judged based on their readmission performance, where hospitals that have higher than expected 30-day readmission are penalized with a goal to improve the readmission rate as well as care quality and long-term outcomes. But our previous work has shown that 30-day readmission-based performance may not be associated with long-term clinical outcomes. And so we wanted to look at a different performance metric, which is 30-day risk standardized mortality, to see if hospitals performing high or low based on 30-day risk standardized mortality do better in terms of long-term outcomes. So this was a retrospective cohort study in which we took data from the Get With the Guidelines heart failure cohort. This is a voluntary observational quality improvement cohort initiative or a registry that has been maintained by AHA since the 2005, and this includes hospitals from all over the country and includes data on heart failure patients that are hospitalized in different hospitals. So we looked at the 30-day risk standards mortality in the Get With the Guidelines heart failure participating centers, and we stratified those hospitals into quartiles to identify high and low performing centers, such that centers that had high 30-day risk standardized mortality were low performing, and centers that had low 30-day risk standardized mortality were high performing. And then we looked at differences in long-term survival and 5-year mortality among heart failure patients that were hospitalized in these high and low performing centers. So we observed that hospitals that perform high with regards to 30-day risk standardized mortality rates did better with respect to the overall median survival in heart failure patients as well as 5-year mortality. The median survival in high-performing hospitals was more than 700 days for heart failure patients, and in low-performing hospitals it was close to I think 570 days. And also there was a significant difference in the mortality rate at 5 years, with an absolute difference of 4% between the high-performing and low-performing centers. We also observed that the survival benefit from being hospitalized in a high-performing center is maintained after the 30 days, and it continues to accrue over time and is not completely attenuated if you landmark the analysis at the first 30 days. I think our study findings have an important implication for the health policies. The current performance incentives for hospitals are all driven by readmission metric, and hospitals that have higher readmission rates have to pay penalty to the government or the CMS with a financial incentive to lower the readmission rates. But our study findings suggest that 30-day risk standardized mortality may be a more powerful predictor of long-term outcomes and survival, and I think that needs to be accounted for in the performance metric assessments that we currently do, and it may be time to move the needle more in favor of mortality-based performance assessment rather than readmission-based performance assessment. I think there's a lot to be done. This is just a starting point, and I think we need to understand what drives the survival differences between high and low performing centers for the based on the 30-day risk standardized mortality rates. And I think we need to understand how the care quality differs and what happens to the patients after they get discharged, and how these different process of care measures are accounted for and how they contribute to the overall survival differences.